Okay, I think we'll go ahead and get started. I'm sure some people will continue joining, but I want to keep us on time as possible. Welcome everyone to our Implementation Science Seminar Series. My name is Dr. Alethea DeRogers. I'm an assistant professor in the Department of Psychiatry and Human Behavior at Brown University, as well as a faculty member within our new rebranded Bridge program. So our implementation science core in the Department of Psychiatry and Human Behavior at Brown has recently rebranded as the Brown Research on Implementation and Dissemination to Guide Evidence Use, or Bridge program. This is the 6th year of our implementation science programming, and we are thrilled to be able to bring these seminars to our Providence and Rhode Island community of implementation scientists, as well as those of you who are joining us from other states or other potentially parts of the world. We are grateful for the partnership of the Advanced Rhode Island Clinical and Translational Research, or Advance-CTR, for supporting the technology, logistics, and marketing of these seminars. And we also recognize our partnership with the Brown Alcohol Research Center on HIV for their support. Today, I am thrilled to welcome Dr. Ruben Martinez as our presenter. Dr. Martinez is an assistant professor in the Bridge program in the Department of Psychiatry and Human Behavior at Brown University. In the Bridge program, he engages in consultation, mentorship, and training related to implementation science and serves as a site PI and co-investigator on several federally funded grants, including the IMPACT Center, which is an NIMH Alacrity Center focused on optimizing implementation of evidence-based practices in low-resource environments through the development of pragmatic, equity-focused implementation methods. The title of his presentation today is Who Gets a Say? Novel Methods to Improve Equity in the Implementation Process. Thank you so much for presenting today, Dr. Martinez. We're really excited to hear who gets a say. And just as a reminder, everyone, you can put your questions in the Q&A, and we'll leave time at the end to have, you can put questions in the chat as well, and we'll leave time at the end for Q&A, hopefully at least 10 to 15 minutes. Okay, Dr. Martinez, I'm turning it over to you.
Great. Thank you, Dr. DeRogers. It's great to be here today to speak with you all about these methods that I'm really passionate about. I'm going to start with discussing, talking a little bit about implementation. I want to give a nice background and foundation for where we're starting and where we're headed. So I took notes from my colleague, Dr. Hannah Frank, on how to start this presentation. So I'm going to start with this really simple teaching tool around implementation science that was developed by Curran, and I put the citation there, is in 2020. So implementation science, it starts when a thing is being put into practice. And so we have these multiple lines of research on the thing. So the thing could be a pill, a policy, a procedure, a treatment, any sort of intervention. Efficacy and effectiveness research tests whether that thing works. So if it's a treatment for depression, does it work to treat depression? Implementation research studies how to best help people do the thing in the best way possible. But sometimes over the course of these kinds of studies and these kinds of projects, equity issues arise. And I see two different kinds of equity issues arising. One is that not everyone is given equal access to the thing, or they don't receive equal quality in receiving the thing. So if it's a treatment for depression, perhaps folks who are in under-resourced environments don't get the same access to that treatment, or the access they get is maybe not complete, or it's not as high quality as it needs to be clinically effective. That's one. Those are what I call those are inequitable implementation outcomes. Another equity issue that arises in implementation research, especially, is that people who are in the implementation process, so the therapists, the people that work at the front desk, the folks that work in records and registration, they don't have a lot of say in how things get done. And so they don't have equity in the implementation process. And by equity, what I mean is they don't have assets and ownership over the implementation process, which can oftentimes lead to folks feeling very disenfranchised and not perhaps doing the thing in the way that we think is the best way to do it. So these are two separate equity issues, and I know equity can be defined in these different ways. We're going to talk about methods today that we are using to try and address some of these issues that come up. Equity and implementation research has really just started to be talked about. So Anna Bauman and colleagues have really started to put this into motion very recently within the last 2 to 3 years. They define equity and implementation research to be explicit attention to the culture, history, values, assets, and needs of the community, integrated into the principles, strategies, frameworks, and tools of implementation science. So I spend a lot of my time thinking about what are our opportunities to integrate things like culture, history, values, and assets into the implementation process. And how can we use those things to address things like inequitable implementation outcomes? So people not getting the thing in the way that we think is ideal for them to receive the thing, the treatment, the policy, whatever it is. I was really lucky a couple years ago to be brought into the IMPACT Center. The IMPACT Center is funded by the National Institutes of Mental Health. It is an Alacrity center. So the whole purpose of this center was to bring a lot of methods researchers together and focus on how can we optimize implementation through these equity-focused methods. So I don't know if you're familiar with QR codes or not. The little dinosaur, I realize I can point to it. The little dinosaur here, if you point your phone camera at it and you click on it, it'll open up a link and you can go there to that mhimpact.org website. So the way I'm going to discuss these methods is nested within a study, and the study is one that I co-lead. I lead the scientific pieces, and then I also co-lead with Dr. Brian Weiner. So this study is called the Novel Methods for Implementing Measurement-Based Care in Low-Resource Environments, affectionately referred to as NIMBLE. The goal of this study is to tailor implementation plans to improve fidelity to measurement-based care in community mental health centers. I know that's a lot. I promise that I will go into detail about what every single one of those words means in just a second. But our aim, I'm really going to focus here on this aim one. And this aim one is to co-create these plans for optimizing a thing, measurement-based care in this case, for youth treatment and primarily rural Latino-serving community mental health centers in Washington State. So I want to just take a second here and note that this is not a talk where I'm going to tell you exactly how things ended up working. This is a talk where I'm going to describe these methods we're using. I'm going to describe our thinking about them, our best thinking at this point, and how we've piloted and adapted these methods in the hopes that you will become interested in them and you will seek them out and you will try and use methods like this in your implementation research and practice. So I'm going to start really quickly with describing measurement-based care. So this is the thing that we're talking about, the thing that we're trying to optimize. So I'm sure every one of you or many of you have gone to the doctor's office and filled out a questionnaire, something like this, the Patient Health Questionnaire 9. These surveys and these questionnaires can be used for a lot of different things, like screening for depression. But really, one of their strongest uses in psychology and clinical practice is to help guide, build engagement and rapport between clients and their therapists. So in filling out these measures consistently, it's a way for clients to communicate with their therapists how they're doing, where they're going, what needs to change, and it helps to focus treatment. So measurement-based care is the systematic collection and use of patient-centered data, just like the PHQ-9, to build engagement and guide collaborative decisions about treatment. Measurement-based care has received a lot of attention over the last few years. It really came out of this tradition of what's called evidence-based assessment, which started in around the early 2000s. So there's a QR code here for this White House report. In February of 2023, a White House report on mental health research priorities specifically names measurement-based care as a step forward in quality mental health practice in community mental health centers specifically. It calls for increasing the infrastructure and the methods that we use to do measurement-based care. So why is measurement-based care getting so much attention. One of the great things about this is that in and of itself, it is not a treatment. It is an adjunct to any treatment with any diagnosis, including comorbid diagnoses. So for kids in community mental health, where comorbidities, meaning having two diagnoses or more at the same time, where that's the rule rather than the exception, a treatment like this that can be added on to any other treatment is really beneficial. It's something that is very attractive to community mental health centers and to payers as well, insurance payers. So we also know that measurement-based care clinically is effective. There are a number of studies that have come out that have shown that not only do kids and families get better when measurement-based care is a component of treatment, but they actually get better at faster rates. For community mental health centers where you're seeing caseloads in the hundreds, being able to get kids in and out of effective treatment quicker is, again, a very attractive thing. Finally, in doing all of this and helping to focus treatment, build engagement, being clinically effective, it's attractive to client. So it aligns with client interests, it aligns with therapist interests, with organizational interests, and with policy interests. It's really just an ideal way to go about doing mental health treatment. So this is why measurement-based care, we're considering it almost as a proof of concept for these methods. And I'm just very quickly, I'm going to talk to you about what goes into measurement-based care. So when we have these patient health questionnaire 9, the generalized anxiety disorder 7, there are lots and lots of different measures out there. Some might say even too many measures. There definitely are too many measures. The steps to doing measurement-based care, I don't want this to get lost because it is a complex process. So in order to use outcome measures, you have to collect them. So you have to collect regularly these outcome measures over the course of treatment. We have to interpret and share the results of what we find. So just like when you go to the doctor's office and you get your blood pressure taken, you want to know what that means. You want to have it interpreted for you and to understand what it means as you move forward in your treatment and what it might necessitate for your treatment and what it might mean for your treatment. So providers then have to interpret and share that information regularly. And then finally, there has to be a collaborative acting upon of that information. If things aren't going well, how do we reconceptualize and move forward in a different path? How do I help you get the content or skills that you want from therapy to achieve your goals in the best way possible? Outcome measures are ideal for facilitating this kind of communication, but only if you have all of these features in place. I think about it, I'm going to reference pyramids 2 times. This first time, this is sort of like you can't do the acting part if you don't do the collecting part. So every layer builds on the layer underneath it. So we have to collect it to share it, and you have to share it to effectively act on it in a collaborative way that helps you to guide decision-making around treatment. Okay, I'm making a big deal out of measurement-based care because inherent to measurement-based care is also the complexity of measurement-based care. So as you see, it's a multi-step process with a lot of identified barriers already. Kara Lewis, who was also instrumental in this project, did a review in 2019 where they identified well over a dozen big super barriers to measurement-based care. And within those, there's a lot of nuance. And that's one thing I'll talk about is how we've parsed out that nuance to really get at what are the important barriers in this setting affecting these people. These barriers are pervasive, intersecting, and multi-level. So they're not just living alone. These barriers affect barriers at other levels. Barriers at the clinician level, for instance, might affect barriers at an organizational level or vice versa. On top of that, community mental health centers are underfunded, understaffed, and overworked. They don't have a lot of resources to do new things that require complex behavior change. So there are these unique contextual challenges on top of measurement-based care already being a complex process. And what we know about implementation of measurement-based care is that tailoring seems to be very important, but there has been inconsistent success with tailoring these plans to implement measurement-based care. The current methods that we have I don't want to spend a ton of time on this, but I do want to just highlight some of the limitations of the methods that have been used in measurement-based care implementation so far. Number one, I mentioned that tailoring is very important. Tailoring means that we're fitting the intervention to the context. We don't really have a lot of guidance on how to tailor things. Number two, when we do have guidance on tailoring, there isn't a lot of engagement of our practice partners, meaning our therapists, the folks that work at the front desk, the records folks. And we often don't actually do anything that captures their lived experience. What does it mean to be them in their context? And how can that help us understand how we implement this new thing into practice? When we do identify barriers, we oftentimes only use one criteria to measure, okay, this is the thing that we're going to go after. So we identify this barrier. We're going to have people rate how feasible it will be to address this barrier, or maybe how important it'll be to address this barrier. But we don't often rate in a on a several criteria. And I'll talk a little bit more about that once we get to that point. And finally, when all these things do go right, we have barriers that end up getting mismatched to strategy. So when you have a barrier, something that stops you from doing something, you also have a strategy. You create a strategy to address that barrier. So for instance, we don't have a lot of Spanish language measures. So a strategy might be to engage an outside company to do a search for Spanish language measures, or to interpret English measures into Spanish. That would be the strategy, right? And the strategies that we create sometimes are mismatched with the barriers. So we think that this strategy should work to address this barrier, but actually the mechanism or causal link between those two doesn't always make a whole lot of sense. It's not always logical, and it's not always well thought out. So I'm going to talk to you a little bit about a tool that we use called causal pathway diagramming to help parse out what can be causally linked. All right, so I'm going to refocus us. I told you a lot about measurement-based care, a lot about the methods. NIMBLE, really what we're doing here is we're co-designing implementation strategies to optimize measurement-based care using methods that build equity and prioritize equitable implementation outcomes. So hopefully that sentence I started with, that I said there was a lot of terms in there, I hope that makes sense now. We're really trying to work with our clinics as teammates, as team members, to build assets and ownership from within, address inequitable implementation outcomes before they come up, or document them so we know what we need to address. And we're trying to do so in a way that feels collaborative and engaging rather than extractive. We focused on 4 clinics in Washington State. They served a high proportion of Latino and Indigenous youth. And in fact, there was a high proportion of Latino therapists represented. This is something that becomes really important later when I talk about ethnography. And the other piece of this is that these clinics are primarily in rural areas. So these are not clinics with a lot of access to a lot of outside help. Excuse me. I'm going to take a quick drink before I move to the design. All right. So this is a lot. This is the big picture of the study. This is the design. So we start with barrier identification. We use 3 different methods: rapid evidence synthesis, rapid ethnography or rapid ethnographic assessment, and design kits. Once we identify the barriers, so what is stopping people from doing measurement-based care more or doing it well, we then start the implementation planning process. And in that planning, we use 2 group facilitated methods. One is called barrier prioritization, and the other is called causal pathway diagramming. After that time period, we then co-develop the implementation strategies with our clinics, and then we roll them out over the course of time through various strategies like team meetings. We send out a monthly news flash that Abigail Madsen, who's at Kaiser Permanente, has been really great at helping me figure out the design for. And then we're monitoring the fidelity. So are they actually using measurement-based care more to a greater extent after the methods that we put into place? Okay, so I'm going to tell you a little bit about, remember, the focus of this talk is on the methods, okay? I'm going to tell you some of the results, but we're just getting into our second cohort right now. And so the results are not final by any means. That'll be for a future talk, but I really want to focus on methods for this. So we have rapid evidence synthesis, rapid ethnography, and design kits. So one other limitation of implementation research is that many times literature is not incorporated into the implementation process. Literature, the scientific studies surrounding an intervention or implementation of something are not perfect by any means, but they do provide an excellent foundation for how to move forward. Unfortunately, systematic reviews, which are systematic searches of that literature, they require immense resources. I've heard funding can be up to about $100,000 for a well-funded systematic review. And every graduate student in here who's done like 5 of those for free is probably very sad to hear that. But emerging methods for rapid evidence synthesis make these timelines faster. And so we're talking about weeks rather than years, low months rather than double-digit months. And the purpose of what we're doing is to synthesize what we know about implementing a certain thing in a certain context to help inform our implementation. And we want to balance the rigor, the scientific rigor of what we're doing, and the resources with the purpose of the synthesis. So for our synthesis, what we did over the course of about 6 weeks is we used rapid review to identify measurement-based care barriers with youth and under-resourced settings. And so what we did is we also focused on what are the documented inequities in who gets measurement-based care, and are there any that we can speak to as we start our process. So we saw studies that surface barriers to measurement-based care, studies that were done in mental or behavioral health settings, and focused on youth mental health treatment. As part of the rapid review, we identified 328 unique articles. After the review process, we ended up with 14. We identified 106 barrier statements. And what we did is we actually took this review that I mentioned before that Kara Lewis and all did, and we actually, because it was such a nice foundation and model, we ended up just adding nuance to the barriers that they had identified. Or if they weren't identified in that model, we added them on, we tacked them on at the end. And we were, as part of this, we did have this focus on what are some inequitable implementation outcomes that have been observed. And we did document multiple of those that helped us to frame the next step of our barrier identification. So we identified that typically the languages that measures are in is a problem. And I'm going to get into a lot more detail about that soon. And we also identified a technology gap. Frida Liu and colleagues at UW had a really great paper on this that really documented how certain folks within that UW psychiatry, University of Washington psychiatry system were getting measures consistently and some weren't. And so that was another piece that we integrated into our ethnography and then later into our implementation planning as well. Okay, so that was method 1 of barrier identification. Method 2 was called rapid ethnography. This is taken from the field of sociology, and the purpose is to take an ethnography, which can take a very, very long time, and try and do it in a quicker amount of time with a stated purpose. And really what I think about that purpose being is getting an insider's perspective without being extractive. Our purpose as researchers isn't to come in and take data out, it's to enrich the environment and to build connections with our partners. So we really wanted to take this holistic approach to understanding the cultural system and sociocultural context that was surrounding our clinics and also the context within our clinic. We did this with 3 interviewers, but we could do it with less. I'm taking most of the interviews for our second cohort. You could do this with 1 or 2 people. And there's a combination of data streams. So this isn't actually just interviews. So we did do some highly flexible interviews, but we also did a lot of observation. So you might ask folks to complete a certain task for you. So can you show me what it would look like to enter this measure into your EHR? Can you show me what it would look like or where the scan box is? can you show me what the records room looks like? Where are the measures kept? And so you're walking around and you're also getting a sense with your own expertise. Well, what are the things that might get in the way? What are the barriers that might get in the way of using outcome measures in this setting? With that data, as you can imagine, there's a lot of things you get from it, but we end up with a lot of field notes. And we integrate those field notes into a rapid thematic analysis that's flexible and iterative and incorporates all data streams. We also took reflexivity notes, and I'm going to talk about that here in a second as well. So this is a really flexible process, and it's extremely rich. And Lorella Palazzo, who is the researcher at Kaiser Permanente, who's really focusing on moving this forward for the Impact Center, is a wonderful resource if this is something you're interested in. So what we did to prepare is that I created what I would call a dossier on each of the clinics. And so this dossier was really focused on what was the purpose of the organization. So if it's a community mental health center, what is their stated mission? What is the sociocultural context surrounding that? So what is it like to live in Eastern Washington? What is it like to be a migrant farm worker in Eastern Washington? So I really took all the information I could find and pared it down to 4 or 5 important documents. And we everyone who visited the clinics, that was part of our preparation process to read that dossier. We trained on a flexible interviewing guide. So we created what we call episodic profiling forms to record data, especially for the interviews. And it's just a Microsoft form similar to a Google form, and just a way that we could organize some of our thinking. And finally, throughout this process, I encouraged our team to discuss our positionality and how it related to what we were finding and what we were seeing. What I found myself was that as a Latino man going into these clinics, I was given access to a lot of information about the culture and the climate of these clinics because of who I was, because of my identity. And that really actually, the quality of what I got was much different than the quality than the other interviewers got. And by quality, I just mean the characteristics of it are different. But what we found with this method, we identified well over 100 barriers from this. What we found is, if you just take a look here at the first cohort, yes, the therapists identified a lot of important barriers. But if you look at some of these other folks, so case managers who are not involved in patient and clinical care, they came up with some important barriers. The clinic administration support, so the records folks came up with significant and important barriers. So this wasn't just the quantity of them, but the quality of what they came up with was actually really important. And we did have also even folks who were just new, who had identified barriers, like trainees who hadn't been there for very long at all. So this is a really powerful method for understanding the context. Okay. As we were doing rapid ethnography, we were also recruiting people to do design kits. Design kits are also called cultural probes or technology probes. They are a packaged set of prompts and activities aimed at understanding a local context. Really, what they were adapted from is the design literature. So user-centered design folks started creating these packaged sets of activities where they direct, please write in a journal about X thing or create a map of Y thing. And the purpose is to stimulate creativity from a design team. Impact has slightly shifted the purpose, and there's only one other paper right now that I know of that does this, where really the design kit is meant to identify barriers. So it's a slightly more targeted approach to these cultural probes or technology probes. We've created these for youth and therapists. They complete them over 7 days. It's somewhere between 5 and 10 minutes per day. And one challenge to this, I'm just going to throw this out there, is that this was not something where there is any sort of analytic method involved. And in fact, the technology and cultural probes I mentioned, there isn't an analytic method to them. It's really an exercise to stimulate their thinking around this thing they're designing, whether it's an app or whatever it might be. Here's an example of one of the activity cards from our youth design kit, where we ask them what it's like to fill out questionnaires about how you've been feeling. That's a broad question, so we provide some extra prompts in there that they can read. This is what they looked like. So in each design kit, there is a box. There is a disposable camera, which is the artifact for recording. So in other instances, this could be something like a video recorder, a digital camera, an audio recorder. You can imagine all kinds of different ways you can do this. We provided a stress ball as a nice gift, something that to show our appreciation, along with a couple pieces of chocolate, which has been also done in other design probe, more of the practice side of design probes. And then, as you can see, here's our impact logo journal, 2 pens, and then these are the activity cards. So this method is one that is really new and one that we're really hoping to move forward. There's a lot of interesting applications we can think of for clinical practice. It is, however, very challenging. Just to go back to this slide here, the fact that they're physical boxes makes it challenging for space and for storage. We did have prepaid envelopes where folks could, all they had to do was put their journal in the envelope and put it in the mailbox, and that was it. But it really has been a difficult method to develop and design. And so one future thing that we're thinking about is how we can engage youth in a co-design of this method to really figure out what would they really like to do to help us identify barriers. Like what kind of activities would they like to do? How would the questions be worded? Is this better as an app than as a physical box? So a lot of questions here. So just some, we did all 3 of those things to identify barriers, just to reorient you. Some examples of barriers that came up from this. So one of the barriers that Lewis and all had identified was that folks were concerned that their outcome measures would affect their relationship with their clinician. We didn't actually find that to be a prominent barrier, but what we did find to be a prominent barrier was that clients had significant concerns that if they got below a certain score on their measure, that they would immediately be kicked out of treatment. That's a really important nuanced barrier to have. So they really believed that there was no communication from the clinics around, we use these as an adjunct to our clinical judgment. Just because you reach a certain score doesn't mean that we're going to kick you out of treatment. And that also affects the way that clients complete their measures. If they're over-reporting for that reason, they're not reporting accurately. We found something very simple, which is that clinicians just didn't understand the outcome measures. They didn't know where they came from. They didn't know what they meant, what the words meant or represented. They didn't understand really what the scores meant in a lot of cases. And this was ranging from trainees to people with over 20 years of experience in youth mental health. This was something we saw pervasively. And that has also led to some changes in the way that I do the training around measurement-based care. And I did forget to mention, I do a 2-hour training before all of this as a precursor to implementation. So it's not part of the active implementation phase. At the intervention organization level, we found a lack of high quality Spanish language measures. And what we found were a couple different issues with these measures. One was that the measures themselves, they were the dialect. So Spanish in Mexico versus Spanish in Colombia versus Spanish in Cuba, all of those Spanish, they're different and they have different words and different meanings for those words. And so for our clinics in Eastern Washington that were serving primarily Mexican immigrants, some of the measures they had just didn't represent the wording, the language that they needed. And sometimes they even felt that the actual concepts being measured were not applicable to their clients, meaning their clients couldn't understand the concepts of the measures. That's just one of the pieces of this measure language issue. This is a broad, multifaceted problem. At the clinic and organization level, we found a lack of clear documented expectations around measure use. One of the things we discuss here, and I have here is in the organization space, is that there's no shared vision around measurement-based care. And a shared vision is not just this where are we headed and where are we going? It's also communication about expectations. How often should you be doing measures? What measures should you be doing with what types of patients? Should you be doing multiple measures? When do you stop using measures or start using measures? So there was no real guidance around that, and it was expected to be delivered as word of mouth. So we identified these barriers, we compiled them into a huge list, and because there were more barriers than we could possibly hope to address, we wanted to prioritize where are we going to head after, and then we wanted to do our causal pathway diagramming, our planning process. But first, we wanted to recruit an implementation team. So what we wanted were a group of people that were invested in this process, invested in measures and outcome measure use. And we also wanted a representative group. So we didn't just want therapists. We didn't just want leadership. We wanted supervisors, therapists, leadership, front desk, records and registration. We wanted people who represented the different processes and components of measurement-based care, because those folks are involved in scanning the measures and giving them to clients, et cetera. And so we hope that this implementation team increases engagement, builds ownerships and assets in that implementation process. And I compare this a lot to the alliance in therapy. So the alliance in therapy is it's not just that warmth and that bond you have with your therapist. It's the extent to which you're on the same page about what you're doing and why you're doing it. That's a crucial part of how people get better in therapy. And I believe it's a crucial part in implementation, which is that with our implementation teams in our clinics, we want to have these connections, these bonds, but we also want to be on the same page about what we're doing and why we're doing it. So we ended up trying to get 6 to 8 people per clinic, which we were successful with in our first cohort. And then we did a group facilitated method using member checking to verify what we found. So all these barriers we came up with, we used member checking, meaning that every single time I read a barrier to them, I said, this is what we found in this clinic, and this is the meaning of this barrier. So you're going to see a survey in a second that's bare bones, but I described each barrier in detail as we went through them. This is an opportunity to probe for gaps and nuances and identified barriers. What didn't we get right? You all are the experts in your setting. You're the experts in community mental health. What did we miss here? Are any barriers coming up that we just totally didn't get? Are any coming up that just you feel are not quite right? So again, this process builds equity. It builds these assets and this ownership in this implementation process because this team is helping to prioritize barriers on a number of different criteria. So we are going to have, for each one of these methods, there will be a publicly available toolkit that's coming out. So Brian Weiner is working on the barrier prioritization toolkit right now, and it's very close to being done. He has a number of criteria in there. So there are lots of criteria by which we can rate different barriers. The ones that we chose for this project we chose 3 different criteria to rate on. So importance, which is how important is this barrier? How much does it affect clinicians' use of measurement-based care? Frequency, how often, how frequently does the barrier affect clinicians' use of measurement-based care? And then addressability or feasibility. How addressable is this barrier? How feasible is it that we can address this barrier? So we had them rate these measures on these 3 criteria. Brian is working on a way to do these very fancy 3-dimensional go zone, no-go zone plots. And I opted for the very simple version of this. So they rated somewhere around 50 barriers. And this whole meeting was about an hour and a half. And what I ended up doing was, instead of creating a really fancy plot, I just said, well, basically the go zone is really any barrier that's above the mean on every single criteria. So that's what we did. We basically calculated, is it above the mean of every criteria? And the ones that were the ones we moved forward with for causal pathway diagramming. So now we've identified barriers. We have prioritized which ones are the most important. Now we have to go about planning how we're going to address them. To do that, we used, as I mentioned, this method called causal pathway diagramming. It's very similar to a lot of other logic models and driver diagrams, those kinds of visual decision-making aids. And the purpose of there are many purposes of CPDs actually, but the purpose of it for us was to increase decision-making ownership, clarify the causal process and chain for how we believe our strategy addresses our barrier to get to our outcome. And it clarifies again who owns what. Really, we're building that alliance within our implementation team. Who's going to take what thing? So these CPDs can be very complicated. I picked a middle of the road one to show you as an example. The implementation strategy here on the left-hand side that's not the first thing we do. So first we populate the barrier. And to do that, I reiterated the top barriers. We gave folks an opportunity to rate which of the barriers they thought they wanted to work on right then. We gave a short menu of strategies that we came up with, but we also allowed them to brainstorm strategies. We voted on the most promising strategies and we completed our CPDs. So we started with the barrier and our outcome was measurement-based care fidelity. We then rated and ranked the implementation strategies, and then we talked through what is the mechanism, what is the how or why does this strategy work to address this barrier? So what is it that's making this tick? And we did it as a sanity check too. Okay, we want to make sure that this strategy aligns with this barrier. So these are just some examples of the causal pathway diagrams that we came up with. We actually ended up with 12 to 15 per clinic, and those all were different strategies. From there, we really tried to focus on, okay, which are the ones we can do, which are the ones that our clinics can do, how can we make this work? From there, we created a clinic report that had all of the causal pathway diagrams within it, as well as the top 10 barriers that we found for each clinic. And this was disseminated to all the clinicians, the implementation team, and leadership. So that was the big process of how we're doing our tailored implementation plans and trying to build equity and address inequities before they happen, or address inequities that are already happening. So some of the lessons I've learned so far is that in doing this, we're getting some extremely rich data, and it actually enabled crosstalk between departments that it was very clear had never talked to each other. So for instance, the records and registration folks had never talked to the clinicians about their process to scan things. And the front desk, who had been actually giving some of these measures, we found out that they had felt extremely uncomfortable giving these measures, especially those that were focused on trauma. So one of the strategies we came up with was to create an FAQ and a script for them as they introduce their outcome measures. But with that being said, with more voices and more crosstalk, you also get a lot more personalized information. And in organizations where punishment is not uncommon, or that punitive approach to feedback is not uncommon, it can create some vulnerability within the organization, which is really important. I mentioned that REA, that ethnography is very powerful. This is one of the ways in which it's very powerful. So these methods require discretion and intention, and really, again, focusing on, we're not extracting information here as researchers coming in or as practitioners coming in. We are hoping to build networks and connections. One thing I keep finding over and over is that leadership can make or break implementation. This is something that we can also assess really well with rapid ethnography. In the shadow of the pandemic, community mental health is very, very hard to do. Research community mental health centers is very, very hard to do. And it is still a very difficult place to work. This project has been really challenging for me, both personally and professionally, because it has been so complicated. And so where are we headed in the future? I know I have 1 or 2 minutes here. So we are going to work on aim 2, which is, so did all these methods actually make a difference? Did they change how much clinicians are using measurement-based care? We're going to focus on these toolkits, these publicly available toolkits to describe how anyone could go about using these measures. We're going to do so in a co-designed setting. So we're going to co-design with our clinicians, people who've been involved in the IMPACT study, how they would like that information to be communicated. We're thinking a lot about future funding on refining design kits, the potential for large language models to innovate rapid evidence synthesis and leadership and coaching in the context of measurement-based care implementation. And really, one other big step, I think, is to define better and really think about what do we mean when we say equity and implementation, and how can we really build and integrate those systems into what we're doing. If you're interested in any of our specific methods, you can contact Renee Hawks. If you're interested in the Impact Center broadly, Michelle Chan is our wonderful center administrator. And if you're interested in the NIMBLE study at all, please feel free to contact me. And so I think we have time for some questions.
Thank you so much, Dr. Martinez. Your work here on this project is really impressive, how thorough and intensively you clearly, along with your team, were trying to address these issues of equity and include multiple stakeholders. This is a really impressive work. I can get started on the Q&A with what we have posted in the chat first, so please keep the questions coming. The first question is, can you explain what the rapid review process entails? This is a great question.
Yeah, definitely. I was really lucky to have the support of our rapid evidence synthesis experts, Nora Henriksen and Paula Blasey at Kaiser, and they have a work plan that they have put together that's part of the toolkit. And the work plan really says, okay, so first things first, what's your research question and how can you refine it as much as you can? And so by refining it, what we mean is that for a systematic review, you are scoping a review all the time. So when I say scoping, I mean that the content that we're looking for can be more broad or more general or more specific. With a rapid review, because you want to have it done so quickly, you have to be really thoughtful about how you scope that work. Because for me, if I looked at every single study for adults and kids doing outcome measurement-based care, that would be way too much to fit into a rapid evidence synthesis. So step one is creating a well-scoped, highly specific research question that you want to answer. Step two, it really then follows those steps of the systematic review, but what makes it rapid, which doesn't mean fast necessarily, but what makes it rapid is that you are paring down some of the things that make systematic reviews so rigorous. And so that means that you go from, instead of having two people do inclusion exclusion or having a significant overlap of inclusion exclusion, maybe you're doing one person does inclusion exclusion and that would be the expert does that, or that two people take half of the articles and there's no overlap. And then from there, every single step beyond that, so inclusion, exclusion, and then you're really focusing on data abstraction. So one person does data abstraction rather than people doing double data abstraction. You basically just cut what needs to be cut to get things done in a quick way where there is still scientific rigor. So the purpose of rapid reviews is not to publish them. The purpose is to identify as much information about a given topic as you can as quickly as possible. That's good, that's helpful and useful. So if you're interested in that method, we are happy to share the toolkits as they are right now. And there is a rapid evidence synthesis toolkit that actually walks you through that whole work plan, which took about 2 weeks of back and forth to get the work plan settled. And then the whole review after took about 6 weeks. So please email Renee if you're interested in that toolkit, and she can connect you with Paula and Nora, who are incredible resources.
Thanks so much. That was a great explanation. The next question is, can lessons learned from the community health group at Washington translate to clinics in a different geographical part of the US that might have some similar patient demographics?
Yeah, absolutely. I love this question. The barriers that we identified, I think, are so pervasive in community mental health centers, and that's across the United States. Many community mental health centers have the exact same general set of problems, which is that they're underfunded, under-resourced, and there's a high pressure and demand on them. And for us, when I think about some of the issues that we saw, which is related to, number one, the measures not being in languages that that clinicians needed them in, and two, some clinicians having a lot of beliefs around who can benefit from measures, outcome measure use. Those lessons are really generalizable. And I found that because, so I've given trainings on measurement-based care now for the University of Buffalo, their social work program, and then in other places around the country. And what I found is that the same exact questions keep popping up around measurement-based care use, around outcome measure use, who it's beneficial for, who has access to it, and who doesn't have access to it. So I think it's a great question, and particularly with these measures that we use so often, being able to find ways to communicate questions from like the PHQ-9 in a way that is accessible it's a scalability problem. You know, we want to be able to have folks in Cuba, folks in Arkansas, folks in Washington State be able to receive this kind of care.
Thanks so much. I think these issues of scalability can really be translated to other settings, and clearly the amount of kind of human resources that goes into this process, it was so intensive, at least that's what it seems like, that if there's a way to kind of translate the lessons learned and use those lessons learned, it seems like that would help optimize kind of the resources as well. I don't know what your thoughts are about that, but.
Yeah, definitely. It's a very intensive process. And I think that there are some inherent limitations to the study that I haven't really talked about that yet. And one of them is that for things like outcome measure use for clinician behaviors, we often hear this phrase, you know, if it's not in the electronic health record, I'm not going to do it. And one of the issues of scalability here is that, one, we have not co-designed the measurement process with our patients. No child, adolescent, adult has ever been part of a co-design process for outcome measurement. So it's really whatever some psychologists or MDs thought was going to be a good way to measure this thing, and we just did it. The simplest way was the surveyor questionnaire. And there are some EHRs, some health record systems, who are working to integrate that, or integrate text messages, reminders to clients into the actual health record system itself. But until that logistic and systemic issue is solved, there will continue to be inequities and gaps in who gets outcome measures and who doesn't. And it's, you know, adopting a new health record system is a extremely resource intensive process, and it's not something that, you know, some folks just got their new AHR, they don't want to move to another one. So there's a technology limitation that I think is really important there.
Yeah, that's a really great point, and how that can also contribute to the inequities with some of these different abilities to access and effectively use technology.
Yeah.
I have a question actually too, and this is a little bit more related to some of the next steps you mentioned with your research. And I was wondering if you could talk a little bit more about how you plan to measure fidelity and to using this measurement-based care. And then also, I mean, you mentioned one of the barriers was almost like receiving a score or being evaluated, getting a low rating, which is something on the measurement-based care tools, and how that would impact, you know, treatment or other things. And I wonder if so far in the literature, you've seen any of this type of barrier to actually completing fidelity monitoring types of assessments either, like to be evaluated and then to kind of have to receive that feedback, if that creates any barriers to actually kind of like quality monitoring of how well the intervention is delivered.
That's a great question and point. And I'll start with the fidelity piece. One of the big limitations in measurement-based care research is that there is a real inconsistency in what we consider fidelity. And the part of fidelity that's easiest to measure, which is, was this measure collected in this session? That's pretty much it. Like, that's the easiest thing to do. Was the collect portion done? It's not a complete picture of what was done in session. So oftentimes there are the only measurement of anything beyond that, well, there isn't a measurement beyond that. Was a measure collected or not, a 0 or a 1? And if we think that the active ingredient in measurement-based care is the sharing, is the, the attention to our clients, we're hitting a bit of a mismatch there. So we have two different methods for measure collection. One is more traditional, which is that we're getting EHR data that is basically, was the measure collected for session by session for each client, and then what was the measure and what was the score. That's the collect component. Because there's no mechanism in the EHR to do anything beyond that, we are doing self-report for the other components of measurement-based care fidelity. So we also have asked, modeled off of a measure that Aaron Lyon did, what's your caseload? In your estimate, what percentage of your caseload did you introduce measures to in the last 3 months? What percentage did you collect from? What percentage did you share results with? And what percentage did you act on? Did you do a collaborative acting on? So that's how we're trying to tackle this really complicated MBC fidelity question. I gave a talk in Dublin where there's some really unique stuff going on around the world where they're asking clients, actually, did you discuss this with your clinician? And what was that discussion like? And so those are some other ways that you could build it in. And I do think in general, to answer your question about fidelity, is this broader issue that clinicians feel anxious about outcome measures. They feel anxious about the results. They feel anxious about discussing them. They feel anxious about introducing them. And clients can sometimes feel anxious about them as well. And that creates a mismatch. And I don't think it's been demonstrated, but I do think that that mismatch, that difficulty, the anxiety around those two pieces makes measurement-based care harder to do. It's a barrier that we identified in all of our clinics so far. So it's a complicated question, and we're just getting into this measurement-based care. I say the next 10 years or so are going to be the biggest measurement-based care research years that we've ever seen. So great question though.
Yeah, no, thanks for that response. And I appreciate, kind of how you're thinking about it. And I'm sure others do too, who have been able to join us today. So we just have 2 minutes left. So I think unless there's any other burning questions, thank you again so much, Dr. Martinez. This has been a really, really interesting talk. And I invite everyone to attend our seminar next week again on Tuesday, October 31st at 12 p.m. We'll have Dr. Andrea Eisman presenting on costs and economic evaluation of implementation strategies in community settings. So hope to have many of you join again next week, and thanks for joining in today. Take care.